the patients that have been registered through Simon's VIP. One of the things that I know is going to be a little sort of confusing for the patients, is that these are people that have gone all the way through the consenting and filled out, they've given us our lab reports, gone through the what we call the medical history interview. So they've gone and done several things. There's some families that are stuck probably earlier in the process that haven't gone through all those steps. So they're not necessarily included in the counting right now, so anyway, whatever we can do to help the families get moving along, and if it's just they got confused by registration or confused by the consent or something else, let us know and we'll be glad to shepherd them through. But anyway. Probably the most important slide on here for everyone else in the room is going to be the slide that's got the mutations as soon as it comes up. So what you'll see is that we do have not an even distribution of mutations. So it's not radically different than what we saw last time, to be honest. But what you'll see is we do have a couple new mutations that we didn't have last time we did the presentation. I think most of you know about most of these mutations already, so I don't think there's going to be anything incredibly shocking. And of course, we'll pass the slides around or post them or whatever we need to. But the basic sort of take-home message that I'll give you is that when we talked last time, when we were out in Phoenix, I guess, the clinical impairments for the children, well, let me also say that one of the things since we met in Phoenix, we had a family meeting in August. I think the family meeting was very useful reciprocally, both for the families as well as for us. Within that, it helped me to get a better sense of the spectrum, and I will say that just in sort of just overall gestalt, most of the kids, I think, are in sort of clustered within a certain range of abilities, but I do think there's some outliers, and I think there's some important things to learn, which I haven't completely figured out yet from the outliers. Most of the kids, as you'll see from the distribution, tend to be young still at this point, so I think in terms of how much we know and how much we can predict, it's somewhat limited, but we do have a couple slightly older individuals, young people, that I think will be helpful. And at the family meeting, one of the things we did, and for those of you who don't know Jennifer Chernagle, maybe I'll just let Jennifer wave her hand here. So Jennifer actually helps me and was at the family meeting that we had and helps in terms of keeping track all the biospecimens we have, all the cell lines, all the samples, all of those types of things, and helps keep me straight in terms of the database that we've got. So if there are any particular access to individual cell lines or mutations or anything like that, certainly let us know and let Jennifer know, and we'll put you in touch in terms of being able to get access to any of that. So,
I'm sure if this is the right one. It says 12-1, but I think it's 12-5, right?
yeah, there would have been one in the presentation. If you could just sort it by date, and that's the easiest way to find the right one.
Copy the file.
Yes, you can just put it on a desktop if you want. Anyway, so the distribution of mutations, I think we've got 8 mutations that's in the most common, they're all missense mutations, 8 in the most common, and then we're distributed almost relatively evenly between the rest. But we continue to be clustered in the same domain, so in terms of the protein modeling and things, I don't think we're way off from where we were before in terms of thinking about this. For the families that I'm not showing here, at least from the ones that I've seen personally, even if I only saw the genetic test report but didn't see all the rest of the data, it's not going to be wildly different. So I think in terms of what we think about which alleles to look at, which domains of the protein, I think basically this is going to continue to be about the same story with minor variations.
So Wendy, they were now probably not discovered through whole exome sequencing, but through candidate?
No, almost everyone is still being identified through whole exome sequencing, right? So that in terms of just from a clinical point of view, our clinical workflow still to diagnose kids with neurodevelopmental disorders at this point is still exome sequencing. And for better or for worse, and I don't know, Megan may be able to chime in here, I mean, I think it's still, the numbers are increasing in terms of the number of people getting testing, but they haven't gone up by an order of magnitude. You know, we're still sort of slowly creeping up. Okay, so.
We do have we have 45 families now, I think. 45 children.
Okay, so you can just do full
So
screen.
all children are single chromosome mutation or both?
If couple have more than the single, but I'm not sure. And I think Wendy will cover some.
Yeah, so anyone who actually had 2 mutations, I've actually excluded from this to make it clean. So I do know of one patient that's got 2 very interesting, the two different mutations which confounds sort of your understanding of this, so I've actually taken him out of this.
You mean mutations in the same gene or no?
Different gene. He's got two completely, just bad luck essentially to have two completely different genes, but it is confusing because, for instance, one gene can cause microcephaly, one macrocephaly, and if you put those two together, you can get a normal head size. And I didn't want to sort of mislead people to think what the phenotype was. You can just keep answering. So anyway, so the total that's represented here, as I said, it's only 14 individuals, even though we have many more families. It just speaks to the fact that we need to keep these guys going through. Keep going. The age distribution, and if you can see, but this is what I was saying. We've got one young person, essentially, and almost everyone else is really young, pre-adolescent, with the exception of our 14 and our 22-year-old. Next slide. So this is the money slide, I think, for most of you guys. So again, in terms of where we're localized, we're still localized really within this, to me, at least what feels like this region of the protein. The one interest that we've got a couple that are farther away, and we've got one at 420 in terms of the amino acid. All of these are non-conservative. All of these, I should say, are de novos. So in terms of pathogenicity, based on the predictions that we have computationally predicting pathogenicity based on the family-based studies, we know it's really mom and dad, and we really know it's a de novo mutation. So these have passed the level of at least my clinical certainty that they don't have anything else that can account for their intellectual disabilities, and I'm ascribing pathogenicity for this. If you guys tell me that any of this is wrong, certainly let me know, but the weight of the clinical evidence we think is supportive enough to think that this is involved. Is everyone okay with this? And again, we'll pass this list around. Okay, so next slide. In terms of this, again, so this is out of 14 kids, where essentially everyone has problems in terms of neurodevelopmental disorders. That's, I think, not surprising. In terms of the range of this, it's sort of, you have, if you want to think of a Venn diagram, everyone has had developmental delay and some degree of intellectual disability, or, depending on their age, we call it developmental delay or intellectual disability. Interestingly enough, after that, then it becomes more diffuse. So there's some kids that have autism, some kids that have attention problems, but there's really the core of this is just, I would describe as more of a global effect on the brain in terms of just being slower in terms of meeting milestones. Next slide. And so this is now getting into some of the medical things. Next slide. So this has been a parent report and where we can documentation based on medical record review. Again, this is based on the neurological manifestations. Largely what we're seeing is macrocephaly, so larger head size. So in terms of the mouse models, in terms of trying to see something we could predict, that's what I would look at. We're not seeing anything grossly in terms of brain structure, so it's not as if we see a lot of brain malformations. We haven't gone to the point of doing deep either structural imaging studies or anything to be able to quantify volumetrics for different parts of the brain. We haven't done that, and these kids would not be easy to scan to get those data in general. Importantly, in terms of this, this is a condition that we're not seeing high frequency of seizures. So there are some of these conditions where we worry a lot about epilepsy. Thankfully, this isn't one where we have everyone that's got epilepsy. And I think this diagnosis of cerebral palsy is quite honestly just a waste bucket diagnosis that was made before people really knew the diagnosis. I don't think they truly have hypoxic ischemic encephalopathy or anything like that to cause CP. Next slide. We do, however, see some seizures in some individuals, and what I don't know yet in terms of this is it's not as if they get to age 7 and then they have their seizures. It's sort of across ages that we're seeing this, and we are seeing some that are, more complicated, not just simply like a febrile seizure or an incidental sort of thing. Exactly, one of the things that interests me is why do some people have seizures, some people not? Is it just that they're unrecognized? And then we need to do a better job in terms of deeper EEG evaluation. I'm sure we will start, the families are well aware of this now, I think, in terms of getting the EEGs and making sure they're 24-hour EEGs, not just a spot EEG, and really seeing. But I truly think there are some kids that are not having seizures, and if there's some secondary factor or if it's by mutation, these are not clustering by mutation, by the way. So it's not as if there's a genotype-phenotype correlation to put these together, but if there's some second factor, I think this is probably one of the issues that's important clinically, but I don't know the answer yet. So, next slide. In terms of visual problems, I would say these are largely not necessarily structurally eye problems, but they're really much more brain problems that we're tending to see. So things like being strabismus as being one of those that we're seeing, or cortical blindness. Those are things I think that are more central than peripheral, but we are seeing some of the regular things that we see. Not terrible, kids can wear glasses and they're doing fine with that, but obviously we want their senses to work in terms of their brain development. Next slide. With this distribution that we see of gastrointestinal problems, to me, is very, very typical for what we see with kids with neurodevelopmental problems. We think of kind of the brain having, or the gut rather, having its own brain in some way. So sometimes we see reflections in terms of kids that have hypotonia, oftentimes also have gastrointestinal problems with constipation or diarrhea or reflux or some combination thereof. And to me, this is very typical for what we see really across many different either intellectual disabilities, autism, or very specific neurogenetic problems. So this is not, I don't think necessarily that there are very bad specific GI issues that are specific to this condition, but the kids definitely are impacted. So it does take a toll.
I think the diet might really affect the reflex. Is there exploration of different diet for the kids?
Say that one more time.
Diet, in the food intake.
In the diet.
Yeah,
So-
like if you take rice or beans, they tend to cause acid reflux.
So I do think, I'll say what I've seen, and then I appreciate you guys to actually chime in. I do think there are certain things that will exacerbate it, either because when they do reflux, they cause more discomfort, and I think there are probably certain foods. I think a lot of it is sphincter tone, though, in terms of, the sphincter tone that just allows things to come up. I think that tone is lower, and physiologically that's what's going on. But I'm sure there are certain foods that make it better or make it worse.
Yeah, with the order she had reflux as a baby, but she's outgrown it, so it might just be, a lot of babies have reflux, but we haven't noticed anything since, so we don't really have GI problems, anything to report there.
Yeah, actually, I think a lot of the families have reported that they have gastrointestinal issues. Soft stools, diarrhea is fairly common. Jordan will go through phases, and it's like every other week or so. We've adjusted diet, and there's certain things that are sensitive to it, certain things that may make her a little more gassy. We've kind of eliminated a lot of dairy. That seems to have helped. But it's sort of just, it's a little bit cyclical every couple weeks. There are some foods that we've tested, and Carol and I were talking on the way over here. We're constantly testing, right? We're constantly adjusting. We're always, as parents, looking for that thing that's going to make things a little bit better. Statistically, I don't know, Wendy, if it's meaningful, but it does. Even on the Facebook page, we've talked about the children, by and large, do have some eating or digestive issues.
Anyway, let me go on. Like I said, I don't want to ignore these. I haven't seen this as something that's overwhelmingly sort of burdensome, but it is an issue. Next slide. So I would call these as the average amount of infections. I don't think we're seeing evidence of an immunodeficiency. I think they're getting their usual sort of ear infections, upper respiratory infections, but nothing really out of the ordinary. Next slide. And again, in terms of the rest of the lung issues, I would call these typical pediatric lung issues in terms of asthma, occasional bronchitis, but not anything very severe. Next slide. In terms of heart issues, interestingly enough, I don't know that we do have 1 of the 14 that has congenital heart disease, just so that people know about 1% of all children are born with congenital heart disease, and these are small numbers. I don't know whether or not this is going to end up being an increased frequency once we get to 500 kids. We'll see. But what I've seen with a lot of other neurogenetic conditions is that we'll end up having a frequency of about 5 to 10% of congenital heart disease for reasons I don't entirely understand, but I do think it's probably more than one hit. Essentially, this is part of the answer, and there's probably something else in the subset that have that. Next slide. Interestingly enough, and again, I don't know that this is going to be consistent. We do have one child that's more adversely affected and does have end-stage renal disease. Whether this is, again, something else, I don't know, or iatrogenic, I don't know yet at this point, but there is one sort of as an outlier and something that we're just paying attention to going forward. Next slide. In terms of the endocrine issues, we have noticed not all of the children, but they tend to be on the smaller side. They tend to be more petite. They tend to have a little more trouble gaining weight, whether that was some of the GI issues early on. But they don't tend to be extreme in terms of teeny tiny with this. In general, we've only seen one child treated with growth hormone, and that did help in terms of helping them to grow. But I would say most of the families haven't chosen to go that way.
Wendy, quick one. So
Sure.
whenever you have these sort of outlier cases, if you will, there's this kid with renal disease, does this actually map to one particular mutation then, or is it no obvious correlation between mutation and phenotype?
Yeah, so I think part of the challenge, and I'm going to speak for having done the same analyses, but for other genetic things. So the challenge is that you need a large enough sample size to know who really your outliers are. And I have to say, with only 14 officially here, and I know we have more in the community, it's hard to know truly who's being an outlier versus who's just the background and just sort of coincidence, if you will. So that's number one. When you are convinced that you've got an outlier, what I've been interested in is someone outlying in one dimension, or are they outlying in multiple dimensions? And so we do have within, and again, I haven't included him here, there is one child that's an outlier, and he's actually not that much of an outlier, except he looks different. But it's very clear that he has a second mutation, and in fact, when he had his clinical testing, he has an obvious second de novo mutation. The challenge is, if I want to look at a genome, trying to pick out the second hit, I call it a second hit, or the second modifier of these things. On average, each of these kids will have 1,000 variants to try and sift through to figure out what that second factor is, and it becomes, or at least until recently, has become absolutely impossible to predict what that other factor is, because undoubtedly it will be other inherited genetic variants, not a de novo change that just sort of pops out at you. With a lot more population-based data, we now are getting a hint about how to distill down probably the 10 worst variants in a genome that someone has. And so I think if we had enough of these, I could probably start to get a sense, but I would need more than 14 kids to do this, and we'd have to go back and get the primary data. For all of these kids, this is just based on their laboratory genetic results. We haven't gone back to actually go back and look at their primary raw data again. And Megan, we could do that someday if we wanted to have fun on a weekend, but anyway.
I suppose if all the outliers, if you will, were E198K, you could make the opposite argument. You could say that there's probably no.
That's right. So the other thing we do is we do a genotype-phenotype correlation, right? So we try and do by genotype, is there one genotype specifically when you've got large enough numbers of these that seem to be acting differently. Right now, it doesn't look like we've got an outlying genotype based on this, within PPP. Okay, next slide. Okay, so this is just skeletal problems, and again, I would describe this for kids that have hypotonia as sort of the usual. We usually see when they go through adolescence, we have more problems in terms of scoliosis or pectus, and again, most of these kids have not gone through adolescence, so I think we're seeing low frequency so far. Next slide. In terms of surgeries, for the most part, they've been kind of usual pediatric surgeries. You can see 3 kids needed G-tubes, so what that means is we actually fed them directly into their stomach. When they were little, those were the same kids that were having trouble with growth, some of the GI problems, but they don't necessarily stay in for life, and they, have done fine with all of these. Next slide. With the medications, this was something that we've been trying to get at much more deeply, and I know some of the families also are interested in this. The question becomes, if you are in that subset that has seizures, like what's the best seizure treatment? Is it going to be simply Keppra? Is it going to be Onfi? Is it going to be a ketogenic diet? And I think this is, if we see that there's enough problems with this, it's the obvious place to do a deep dive with certain families, and we do. Jennifer knows this very well. We've been obsessing about this recently in terms of what's the best way. Do we actually get the direct EEG data from the families? Do we get a very, very detailed medical record documentation of what medications they were on, how it changed their EEG? But if we get to that, that's probably a high yield thing for the families, for us to think about it, doing a deep dive with them. The other thing has been sleep, and it's not something that affects everyone universally, but sleep is definitely more disturbed. I don't think it's necessarily that sleep is being disturbed by seizures, so I don't want you necessarily to confuse those. But sleep is one of the other issues, and in terms of circadian rhythms and things like that, it would be interesting to understand that from some of the mouse models. Next slide. So with this is what I was describing for the families, and again, for any of the families, all this will be posted. I don't think we have a clear winner in terms of obvious medication that worked for everyone in terms of this. We've put down these notes, and for the group today, I don't think we want to go into lots of detail, but the bottom line is people have sort of shopped around and tried different medications, and there's no clear, either from a mechanistic point of view for the seizures, or just empirically medication that clearly has taken away the seizures. So Go ahead.
These kids are pharmacoresistant.
So this
cohort.
is, and I have to tell you, I don't know, so there's a group of these that are the tried and discontinued. And so although it's an inference, most of the circumstances, I think I think they discontinued because the seizures were not well controlled. And so ultimately though, what's interesting is that they're for the same medication, so for Depakote, for Trileptal, for Onfi, for Keppra, there's some kids though that are doing okay on those medications, and it's tending to get to polypharmacy in some cases, where it's not just one, but it's a combination of medications that may be effective. And I think we're really just going to have to, like I said, for these few families that are having seizures, we're just going to have to do a much more detailed analysis than the simple thing we did on the phone. You know, we did kind of a telephone interview with the seizure questionnaire that we have. But I think if this is, you know, proving to be really something important, we're going to have to dig deeper. Okay.
Question on that. So, would you expect the EEGs, if repeated, to come back normal if the seizure is controlled through medication?
Yeah, so the idea hopefully is that then the EEG normalizes after that,
Okay.
at least if we've got good seizure control, absolutely. Okay, next slide. Okay, so this is just a summary of what we've got back from the humans. Like I said, I think for the most part you can trace this back basically to the brain is what's going on in terms of where the burden is, which is not so surprising. But we are having a little trouble in terms of effects on the body writ large, so some growth problems. But overall, not really any different from what we talked about in Phoenix. Very, very similar, just like I said, we're getting a wider distribution of mutations at this point. And I don't know, Megan, if you want to offer anything, do you have any sense of how, like what, or maybe the families know, with what frequency we're starting to identify more patients? I'm trying to capture, like, how many are out there and how many do you think we're capturing?
Yeah, I
in
was
the-
just speaking, I said I should have gotten an updated count. I'll get that tonight from the database.
Okay.
Well, since conference, we've grown by 10 families,
Yeah.
and we know 4 or 5 more. So
Okay.
they come in cluster, it seems, and it also seems like certain cities are better at diagnosing. So we see like little cities having 3, 4. There's nothing special about there except that
Yeah.
they're able to diagnose it. So it's definitely increasing in frequency. The dots are getting closer together.
Okay. Okay, very good. So anyway, that's what I've got from the human side.
I have a question, Wendy. All this presents to me. Sounds like one thing, Carol, we need to really work on. You need more numbers,
Yeah, yeah.
and so how? I'm afraid that I may be one of those that has been a little bit negligent. But I think, you know, with 45 families now, and at least from the clinical standpoint, you could probably use all 45, right?
Yeah, absolutely. We need all 45.
I
So.
think part of it also, I mean, we're gonna need help because I think many are stuck in the process.
Yeah, I think that's it. I think people register and they think they're done.
Right.
And I think we need to, I don't care whether we do like a quick little 3-minute video tutorial or something that you can post to be able to, you know, just walk people through
Right.
stage by stage.
Or
I'm
all
glad
the
to do
steps
that.
required to get
Yeah.
us to where we need to be or whatever that would
And,
look like.
yeah, we can do that and we can make sure, we've got capacity, I think, or we'll make capacity in terms of being able to help them through and
Right.
do the telephone interviews.
Being the families that are lost.
Yeah, and sometimes, you know, we did this before, but sometimes if we give them a deadline to work towards, that might help.
Yeah.
Help.
So,
when-
go ahead.
Sorry. So for the kids who have a sleeping problem, does it also associate with a GI problem besides, is it the
I don't
maybe-
necessarily think they're going together all the time. And I
Okay.
think this is also, I haven't drawn this out, but there's also a life course issue here, which is that, you know, sometimes, as Carol was saying, you'll have a phase of life where there may be some problem and it may resolve itself, and then there may be a different phase where you've got another problem, so.
Yeah, and I mean, a lot of our children have sleep issues and they have trouble going to sleep, or they wake up very frequently, or they wake up at 1 a.m. and start their day. So, and that's day in, day out. So it's, I don't, frequency-wise, I think it's like 40% of our children, but it's a big impact on these families because they're sleep deprived, basically, all of them. So.
And it doesn't help their parents either.
No,
No.
It's hard.
We had quite a discussion about a month ago about this, trying to find help for the families who just are really struggling with that issue in particular right now.
So how did medicine help with
It-
sleep? Is there help?
With most, it did not. it would help for a period of time and then stop being effective. Or would have side effect like aggressive behavior or anything like that, so they would stop it as a result.
Those 45 families, do they include families that have been diagnosed with overgrowth syndrome as well? I mean,
So these, the
no.
ones I've included have
No.
not included anyone with overgrowth.
Okay, so maybe there's a potential, cohort of kids that would be tapped into, because, I mean, I don't know how often this is being diagnosed here in the US, right?
So I just want to make sure I'm understanding what you're calling
The
overgrowth.
human overgrowth syndrome, there were
Yeah.
a couple of PP2A or RFID mutations that also presented with autism-like behavior and some developmental delay, but probably not as striking.
And they were overgrowth in all dimensions,
Yes, in
or
all
overgrowth in
dimensions.
terms of
It
head
was,
overgrowth?
it was tall stature as well as a large head.
Okay. That's interesting, because I don't know if you guys can think of anyone. I can't think of anyone in our cohort so far. Big head, yes,
They're large
but not,
heads,
Yeah.
but not big overall.
Yeah, I mean,
It's
there's,
actually small feet and hands
Right.
have been reported.
I mean, there's another 6 to 8 cases, I guess. You've seen the paper, right? I mean,
Yeah,
that's a few years ago.
But I'm just saying, for whatever reason, they're not clinically getting diagnosed, at least mostly in the US.
And
they're getting
they're
it.
little, I mean, our average age within the 45 families is 7, so.
Are there any other neurological diseases that have shown close phenotype? I guess I'm thinking more along the lines of this Rett's syndrome or MECP
Yeah.
amplification.
Yeah. So MECP2, I mean, so, and, probably Megan and Jennifer and I would say this, that there are a lot of the genes, that neurogenetic conditions that have been identified through exome sequencing, which you could, in many ways, almost swap gene names, swap mutations out, and they look very, very similar. So this is not incredibly distinguishing amongst many of the others. I don't know if we want to talk about it tonight, but the other thing that's come up, and Megan may have something to say about this, there have been other PPP genes that have been coming up, and maybe you guys have talked about this already, and I'm late to the party, but, so there are other genes that are coming up. As I've seen, and Megan, you chime in, I haven't seen them with the same frequency necessarily. They've been rarer in terms of the frequency that I've seen, but maybe you guys have seen certain ones that are more frequent.
Yeah, we have a study on CA, so the catalytic. It's a bit difficult to follow for me with all the clinical data gathered from wherever. But I think we have 11 patients with mutations.
I think I sent you one, right?
Sorry?
I think I sent you one too. Or anyway,
But
but
that was an A alpha, but
Oh.
maybe
Yeah,
you are.
right, but like, numbers wise, it's much smaller for us.
Yeah.
That's
So I think it's more rare.
yeah.
11 patients is not nothing.
So,
Right.
For which one was 11? Which
So that's the
mutation?
PPP2CA. So that's not one of the regulatory symptoms, but it's the catalytic symptoms. There are also a couple of recurrent ones.
There was a medical geneticist from Poland that has released data that's PP5C as well. He's got the same one mutation.
And we're connected to a few one-offs as well.
yeah, we do want to talk later about the fact families are now reaching out to us with different mutations who are finding us as their home. And I think we wanted to throw that out to you all. I don't know if now is the time to do it or not, but
Maybe during the discussion.
yeah.
Okay.
We have learned maybe also from